Hello, everyone. This is Dr. Carrie Bedient from the Fertility Center of Las Vegas, bringing you another episode of Fertility Docs Uncensored with my two charming, lovely, and delightful co-hosts, Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody.
And Dr. Susan Hudson from No, you're not Nashville.
I'm
You're
not
Texas
Nashville.
Fertility Center.
We would adopt her in Nashville, though. We take her.
Thank you. Thank you. Yes. How are y'all doing?
Good.
Great. Just hanging out.
It's crazy hot here. What's going on? What's going on like in your neck of the woods?
Weather hasn't quite turned here yet, which is sort of good and sort of bad. Like it's been really a not bad summer here for the first chunk of it, which is nice. But I did have to have the exterminator out yesterday because we are hearing critters in our attic. And like I fully acknowledge I live in the Southwest and scorpions and poisonous things are just what we do. But these sound like four-legged rodent type critters, and I did not sign up for this, and I am not okay with this. But hopefully when the weather turns, which is supposed to do later this week, it'll get too hot in that space and it'll drive them out. And so fingers crossed.
They'll die.
They'll get out before they die.
But why would they leave like the confines of like
your nice house,
your nice
cool
house and
because
go
there's
elsewhere?
There's no air conditioning, there's no airflow up there. And so when it's 110 outside in that space in between the roof and like the ceiling where there's all the insulation and stuff, that's going to get a lot hotter than just 110. And so they will walk out of there before they die in there. Because it's cooler outside. Like you can find shade outside and a breeze. Can't do that in the attic.
Hey, I heard your neighbors up to the north, though, have a bit of a plague, and it sounds like you've escaped the plague in Nevada.
Yeah, there's a cicada cycle or katydid, depending on what you call them. And so right now it's grasshoppers. And so there's a lot of grasshoppers around, but it's not a huge amount. 2-3 years ago, there was a huge plague where if you go back and you Google pictures of the strip, everything is literally covered. I mean, you would walk down the strip and it would just be crunch, 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 because all these little buggies were dying at your feet because they were everywhere. I did not go down to the strip at that time. I stayed inside.
Well, when I started residency in Gainesville, Florida, and I think there's some years that are worse and some years that are better, but almost every year in about August in Florida, I don't know what they are. There's some kind of bug, and they call them love bugs because they're together. There's a big one and a small one, and they're mating, and they're all over your windshield, all over your ground. And like I say, the first year I came down, it was like, oh my gosh, what is this? You turn on the windshield wipers and they get smushed all over your windshield. And so yeah, it's kind of gross every year, but some years are worse than others.
I'm not a big fan of critters. I don't really like bugs. I hate June bugs. Do y'all have June bugs?
Oh yeah.
Oh.
So I think June bugs, cicadas, and katydids, I think those are all the same thing.
I don't think June bugs are different from cicadas.
Yeah,
really?
And actually,
June bugs are like brown, beetly looking things, and they fly up and like try to like attack.
Yeah, those are what I call cicadas. Like grasshoppers and katydids to me are like the same thing. They're a little jumping. They don't have wings, whereas cicadas have wings. We have those. They screech all the time in the summertime.
But cicadas and June bugs are different bugs because we have cicadas too.
Cicadas are the ones with the pretty kind of greenish, pearly, iridescent.
I wouldn't call them
right?
Pretty. I call those beetles. I think we need an entomologist.
I'll call
Maybe we should stick to what we know.
We prefer the two-legged creatures versus the six-legged creatures.
Yeah, maybe we should stick to what we know and just talk about fertility today.
Or in furry and scurrying and attics.
Entomology.
Ew, yeah. Okay, let's do questions. Let's just block out the bugs.
Okay, let's block out the bugs. Here's the first one. Hi, docs. I am 38 years old with secondary unexplained infertility. I did one IVF cycle and got 7 PGT normal embryos out of 20 fertilized. I am now prepping for a modified natural FET in which I started letrozole for 5 days and had an Ovidrol trigger shot on day 10. On day 12, my progesterone came back as 1.6, which I'm guessing means I didn't ovulate or it was a poor ovulation. I am taking vaginal progesterone 2 times a day now, but I am concerned that FET will be canceled because the P4 is so low. My question, if my normal cycle is 30 days, why would a FET be tentatively scheduled on day 16 of my cycle? Isn't that too early? Could that be the cause of my low progesterone, even though my follicles were large enough to trigger? Thanks.
Can I take this one? Because I just wrote a whole lecture on it for...
You go for it, Carrie.
Go, girl.
Okay, so there's a whole bunch of issues here. Number one is natural versus modified natural versus a programmed FET cycle. The effectiveness of all of these in general tend to be pretty similar, assuming that the progesterone is good. And so there's a whole bunch of advocates for one or the other. Most people tend to go a little bit more for natural modified than a straight natural cycle, because of the control issues. And
hey, and Carrie, define what you mean, because I think different people and even different doctors call natural modified. I mean, it means different things to different people. What are you talking about when you say natural modified?
so when I see a modified natural cycle, it's typically something done with letrozole, clomid, or gonadotropins. Letrozole seems to be the most common. And then there's 2 different ways to approach ovulation. There's going to be some people who let ovulation happen completely naturally. There's going to be some people who trigger it with Ovidrel, Pregnol, one of the HCGs. And then there are going to be some people who do it, and this is what our practice does, is once we see that the lining's good, we start the progesterone and oil.
That's
and then a day or 2 later, we give you an HCG trigger so that you get a corpus luteum. And so those are the different ways that you can do those modified natural cycles compared with a natural cycle. I kind of like
the way you described yours, because then you still have that precise timing of
and that's
why
I do it.
Progesterone. But you're still getting that natural support by the corpus luteum. Neat.
Yeah, it's it really appeals to the control freak side, and we are absolutely insane about progesterone exposure because it's what Dr. Shapiro, my partner, did a ton of his research on in the early days when he was working on FETs. And so you would not believe the slide deck that I have on progesterone and the different studies that have been done on it, because they look at oral, vaginal, and IM. And so most of the data seems to point to the fact that you get a better progesterone exposure with IM. And so I would be really worried that at the time that you were supposed to have higher progesterone, it was so low, because that's one of the biggest components of not succeeding. So, and vaginal progesterone has a pretty good track record, at least in programmed cycles, of not being sufficient. When I was looking at the modified natural cycles, I didn't see the same data set. Like, everybody kind of was like, yeah, we think this is probably a good thing for XYZ reasons, but we haven't totally nailed the process yet. So with what
just to be clear, with that, you're starting the progesterone, and then your own body's corpus luteum is also producing progesterone. So you're getting 2 different sources of progesterone, right?
Well, with some of the protocols, right? And so, avenue of how you get the progesterone, oral, vaginal, IM makes a difference. I haven't seen any data that supports oral at all for the purpose of IVF FETs. But yeah, I'd be worried on this one that your progesterone's not high enough, and that you might want to switch that up a little bit. So, listen to what your doctor says, because they're going to have a protocol and they're going to know what works best in their hands. And there is something to be said for that. But that's my nerdliness.
Awesome. You gonna do one more?
Wow. Thank you for answering that question, Carrie. That was brilliant.
Good stuff. Good stuff. Hello, I am 28 years old, and diagnosed with endometriosis when I was 16. I have had 4 laparoscopic ablations since then. My last ablation was November of 2017, and I got pregnant with my first off birth control in May of 2018. Had a healthy boy in January 2019. Tried for a second in 2020, again got pregnant in May 2020, having a healthy boy again in February 21. We have been trying for a third since around January of 2022. Got pregnant and had a miscarriage in September, but have not had any luck since. Recently found out my TSH is 4.34, so I started Synthroid this month, but my AMH was only 0.64. What would you suggest going forward? Do not have another surgery.
Well, there's two different schools of thought kind of as far as endometriosis. Some people in our field believe that endometriosis is outside the uterus. If you do IVF, you take the egg out, you put the sperm with it, you put it up inside the body. That doesn't make a difference. There's another school of thought in our field, which if you listen to Bruce Lessig that we had on a few weeks ago, he believes that endometriosis, even outside the body, can cause issues with implantation in the uterus. It's correlated with an inflammatory marker called BCL6, and that's bad. So if it's present, it lowers, at least in his studies that have been done, which are small studies, suggests that it lowers pregnancy rates in people who are trying to do IVF. And so, back in the day when I started out, 15, 20 years ago, we would laparoscope everybody. And so a lot of times we probably took care of an implantation problem if it existed with endometriosis. And so I'm sort of kind of wavering to the school of thought where I do think probably endometriosis may have some negative impact on implantation. And so, yeah, you could argue that you've had 4 laparoscopies, although I think the last one was like in 2019, wasn't it? Something she said. Been a while ago.
No,
So
it was
was it
I think,
recent?
No, the
17.
last surgery was 2017. She's had
Okay.
2 children since then.
Yeah, so I mean, I think if you're having pain, if you're having other issues, that would be a reason potentially to do laparoscopy. I think if your doctor's of the school of thought that implantation and endometriosis matter, maybe do a BCL6 biopsy. If it's positive, a lot of times we'll treat people now with just Lupron for 2 months. So it kind of depends on, it's kind of a controversial area, I think, in our field.
So let me kind of expand on what I was saying for not having another surgery. Your AMH is 0.64. If somebody goes and ablates some more endometriosis on your ovary, they're frying more of your eggs, and you don't need that to happen.
Yeah, that is true.
You're 28 years old. That's an AMH we would expect for somebody who's 38 or in their 40s.
40, yeah.
Okay. So if there is a concern that you may have BCL6 or endometriosis that comes back, I would be a huge advocate for either Orlissa, the oral medication that can help kind of chemically ablate endometriosis, or doing Lupron. Do that for a couple of months, and then, trying some ovulation induction or something like that to hopefully expedite you getting pregnant. If after 3-4 cycles of ovulation induction with IUI after a couple of months of suppression, then, seriously consider IVF. But I'm not, especially with your AMH level at your age. I mean, the most likely reason is you've had multiple endometriomas or endometriosis ablated from your ovaries. And you don't have the eggs to spare. Carrie?
Yeah. Seen and agree with above. All right. So let's move on to our topic of the day, which is one of the more touchy-feely ones, which is how do you navigate this whole process with your partner? And I think all 3 of us have had experiences, and Abby, you were mentioning one that you've had earlier this week where a couple was clearly not in agreement about what was going to happen. And that manifested itself very obviously in your clinic. And so today, let's kind of go through the process and, in part talk about a little about what we see with couples, and maybe some suggestions of how can couples start to talk to each other so that they can be on the same page, so that those differences can be worked through, because everybody's going to have differences. It's more, how do you deal with them? So when you guys have somebody coming in for the first diagnostic visit, like you haven't met them before, you're just starting the conversation, what are some of the things that you can pick up on as a physician watching all this unfold, where it's pretty clear these 2 people have very different ideas about how we're going to move forward?
I think we're all probably now, whether we realize it or not, experts in body language, because you can just
Mhm.
see, as fertility doctors, and I think most fertility doctors do this, we bring both partners in, whether it's female, female, male, 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 female, whatever. You can always tell which partner, or if both of them are really engaged, just by their body language, if they're leaning forward, if they're making eye contact, if they're, a lot of times if
They're
they're
sitting on
close,
separate ends of my
right, if they're
couch.
sitting closer together or further apart, or if the other partner's on their cell phone, texting while you're talking.
My favorite is the way it works in my clinic when I'm going to see a new patient, they're in the waiting room. I actually go to the waiting room and ask them to come back. And I typically call for the person who is intending on carrying the pregnancy. Okay. That person's name. And when the other partner just like sits there and looks, and I'm like, you can come back too. What I tell them, I'm like, fertility is a team sport.
Yeah, that's right.
Mhm.
And that's kind of a first, sign of like one person's ready and the other person's kind of like, I'm not really sure what I'm doing here.
Yep. Is there, what do you notice when they're answering questions, when there's a discordance between the first half and the second half of the team?
I think the first half of the team that's really enthusiastic, answers all the questions. And sometimes the other partner will be completely, if they're not into it, completely disengaged, not answering any questions. Or sometimes they'll interrupt and be like, well, that's not true. We really haven't been trying for that long. We're, trying to discount why they're even there, to kind of.
There's usually a dominant speaker, and that I think that's pretty normal, like the person who's telling the story.
Yeah.
But how the other person engages and is paying attention, or like dozing off, or engaged on their phone texting somebody else, there's a huge range, but essentially it's how they're, and some of it may not even be verbal. Some of it is just like we said, watching that body language and how they're agreeing and contributing even without saying something.
And Susan, how do you get them engaged? If you can tell the partner's not engaged, what do you do to try and bring the partner into the fold and get that person engaged?
Well, I ask the person who does not seem as engaged, do you have anything additional you'd like to add to kind of your journey so far? Do you have any questions, any concerns? Lots of times people don't have questions. They have lots of concerns.
Yeah.
Yep.
And really making sure that, part of my job is to make sure both people understand we are there for both of them. They are both going through a journey. And sometimes people are, they maybe have started together. They may actually still have the same goal together, because it's really hard when one person wants it and one person doesn't. But ideally, if they're both sitting in my office, I'm hoping they have the same goal of ending up with a baby, but they may be on their own pathways, and kind of helping them get to a singular pathway where they are supporting each other is part of our role in helping through that journey.
Well, and I think sometimes the disengagement too is if one partner is more used to being in a doctor's office, like traditional male-female couples, a lot of males don't go to the doctor very often. And I think particularly if it's not a same-sex couple, or if it's a, heterosexual couple, a lot of times the male partner is not used to being in a gynecologist office. They feel really intimidated. It's, we have a lot of female employees, we're female, and we're talking about a lot of female issues that they don't really want to think about or want to talk about. And it's really kind of, we ask a lot of really probing questions like, how many times a week do you have sex? And do you have, all these problems? And so I think I think a lot of times, at least a male partner sometimes feels very intimidated by those kind of questions.
And I think there's societal pressure of that, like, I'm masculine, I'm a man, and I have always assumed I am virile and I can, create a baby with my, millions of sperm, and like having to actually be faced with doing a test that may or may not support that preconceived notion. I mean, it's one of those things in society that I think, nobody ever grows up thinking, hey, I'm concerned I'm going to be infertile unless you had like childhood cancer or something like that, that you had something that may have actually caused that to happen. And I think women are a little more like, we like to take the blame for things. Oddly, I don't know why we
Yes.
do it, but we're
Women are always
good
like, oh,
on
I'm sure it's me. I'm
guilt
sure
and
it's me.
blame. We're great
Yeah.
at that. And we go in expecting it to be us.
That's
And
right.
guys go in expecting it not to be
Not to be
them.
them.
When the reality is it's often both. Okay. It's often a little something on her side, a little something on his side. And you put those together, and that's how you end up seeing people like us. And that's okay. That's okay. I think one of the biggest struggles I see in couples is when the majority of the diagnostics comes back as it's significantly, say, egg factor or tubal factor, or it's significantly male factor, and there's not something on the other person's, that it's really, depending on where they started out, that is a really hard emotional place to be at times.
Mm-hmm. And how do you guys deal with and see where oftentimes one partner is gung-ho on doing all the testing and the other partner is nope, and they won't do it, or they're dragging their feet? Sometimes it's very apparent, and sometimes it is more subtle of just not scheduling. And I would say, at least from my perspective, it tends to be more in a male female couple, the woman is gung-ho and doing all the things, the man is not. And the reason I say it is because if the woman's not gung-ho, usually the appointment never gets
They
made.
haven't come. They haven't come to see it.
That's true.
Yeah, they don't even come. And so like we have an appointment that's geared especially for the semen analysis in our office when we haven't seen the female partner. And there are lots of times when I will call him and I will say, okay, your sperm is totally normal, but from what you have told me, there's an issue going on. You guys should have been pregnant by now. And so please have her come in, and we'll set up a couple appointment to talk to both of you, and she'll be listening on the other line. She's like, well, it's not my problem. I had 2 babies 5 years ago with the prior partner. This isn't me.
And I'm now 42.
And I'm now 42.
Well, and your point that you made, Susan, it's a team sport. It really is. And it's not a male or female issue. It's a couple issue. And some couples don't see it that way. Some are very polarized that it's your fault, not my fault. And that's really not, I mean, I think if we're talking to our listeners, one thing that you need to think about is make it a couples issue. It's not me or you, it's us. And I think that's the way to sort of engage your partner and get them in the door and just help them understand why it's important that they be tested too. It may be fine, but we don't know. We can't check it off our list until we actually do the testing.
From my perspective, there is power in knowledge. Okay?
Yes,
if
absolutely.
you don't know if you're listening to our podcast, you have a concern about your fertility. Okay. Whether you've been trying for 1 or 2 months or haven't tried at all, or you've been trying for 10 years. Okay.
Or you've been not using birth control and not really trying for more than a couple of months, but not been using birth control for a couple of years.
If you're having sex and not preventing, you're trying. All right. But, it's one of those things that you have to come in together. Y'all are working through this together to create something beautiful together. Okay. And just like you go through different parts of your relationship, maybe one person has a better job than the other person, or one person is going through a family struggle than the other person. Like, that's part of a relationship. And this is part of a relationship. And this is a really stressful part of a relationship. So we've mentioned in prior episodes that a diagnosis of infertility is as stressful as a diagnosis of cancer. So if you're stressed out, no, that is normal. Okay. Come to people like us. We will help you navigate that path. If you need, sometimes under these huge stressful conditions, you may need some additional help. You may need to talk to a counselor. You may need to talk to a counselor by yourself. Y'all may need to talk to a counselor together. Somebody may need some medicine for anxiety or depression. That is okay. There's actually very good data to say that with the right medications, not all of them are our favorites, but there's quite a few that are, with the right medications, our outcomes for pregnancy, including mom, baby, childhood outcomes, are much better when we have our mental health in as good a condition as it possibly can be. So we really are treating the entire person here.
Well, and just to add on to what you're saying, Susan, too, a lot of couples that we see have been married 2, maybe 3 years at the most. And really, this is one of the first big crises that you may face as a married couple. And so, unfortunately, we know that divorce rates are higher in our infertility patients. So I would definitely add on to that, you may need some marriage counseling. I mean, this is sort of the first big dilemma you really have to cope with as a couple. And so I think it can set the tenor for the rest of your marriage even too. So definitely I think couples counseling is a great thing to do while you're involved with this very stressful situation.
So just to make it clear, if we as the fertility doc suggest to a patient or a couple, hey, maybe you should go talk to a therapist, counselor, psychologist, or psychiatrist, are we telling them that they are crazy, unfit to be parents?
No,
absolutely not.
Not at all.
We are trying to give you the armor to fight the battle you're here to fight with us.
And the other thing along the mental health realm is your partner may not say, oh, gee, I'm really depressed. I'm really sad that we're not able to get pregnant. I'm really sad that I see you cry all the time. Your partner may face it by, basically avoidance. I mean, there's different ways that you can avoid or you can deal with stress. Avoidance is one of the ways. Depression is one of the ways. Anger is one of the ways. And a lot of times, and I know Carrie and Susan and I see, unfortunately, quite a lot of angry patients. And sometimes it's both. Sometimes it's individuals. And, they say, and I'm not a therapist, but anger is a mask for a lot of other emotions. And a lot of people
Usually
are really
fear.
comfortable. Yeah, they're really comfortable being angry, but they're not comfortable crying, being sad. And so if you find that your spouse is really just frustrated and angry and kind of takes it out on you, it's really, they're just sad, and we see that. And that is definitely, a call for seeing a therapist. It's really important to kind of deal with those emotions and let everybody recognize what the emotions really are so that you can deal with them.
And realize that going through fertility treatment, whether it's for infertility or things like recurrent pregnancy loss, it is normal to go through the grieving process. Okay. And, there's denial, and then there's acceptance, and there's justification, and all those different stages. And remember that you and your partner may not be at the same stage at the same time. And that is okay. Okay. The thing is to be there understanding. I may be still in denial. You may be under justification.
Yeah.
But we're gonna end up at the end point together, supporting each other. And that's really important.
So to show just how common some of these things are, think about your last 2 weeks in clinic. So all three of us think about your last 2 weeks in clinic. In the last 2 weeks in clinic, have you had a woman cry in your office?
Yes.
Absolutely. Unfortunately, yes. Almost every day.
I have Kleenexes in my office in every exam room. And yes. I have good Kleenexes because when my father was passing away and we were in the ICU and I'm, just water is pouring out of my eyes, and they gave me those cheap ass box of crappy pieces of paper that are wadded up, and they call it tissue.
Shred. Yeah.
Absolutely not.
No. Have you seen a partner cry in your office in the last couple weeks?
Yes.
Mm-hmm.
Have you seen a couple clearly not be talking to each other?
Absolutely.
Like they're in the same place, but there is no communication.
Yes.
Have you seen a couple yelling at each other, raised voices, whether it's just a little raised or full blown fight?
Yes, absolutely. Yes. This week.
And we see it with our staff too. Not that our staff are yelling, but we see patients who are coming across verbally not as pleasantly as they could.
Yeah, I had a staff member cry this week too because of a situation.
Yeah. Like I had a patient write an apology letter to one of my staff members because he was taking his feelings out on her.
Mm.
And so
And a
all of
lot of
these
times I
things,
think when we identify those emotions, I think in patients, and all of a sudden they realize, when they're yelling at you, you're like, for a lot of people, you're really just really sad. And once they start to really realize that, then that's a lot of times when, you can connect with your patient, and the same thing with your partner. A lot of times, if you can help them recognize what the emotions are that they're really feeling, a lot of times I think that's when you make a breakthrough as far as, your ability to work together as a team.
are there any particular techniques that you think are helpful in couples to get them on the same page, to at least get them closer, if not exactly the same?
I think especially when we're posing, if you are a patient in my office and I'm going over your results visit, so I am throwing a ton of information at you. I'm talking about eggs and sperm and tubes and saline ultrasounds and putting them all together and then talking about treatment options. If you can tell that based on prior conversations with your partner that y'all need some time to digest and then come back in a week or two to kind of have that more solid conversation, I am absolutely willing to make that happen. Okay. And sometimes I can just read that into you. Okay.
Mhm.
Sometimes I can see it that y'all are just like, y'all are trying to telepathically talk to each other. And I know it doesn't work that well. Okay. And so, sometimes I can read that and be like, you know what? This is a lot right now.
Yeah, let's just
Let's
stop
stop
here.
here. Y'all go home, have a bottle of wine, have a few conversations, write down your questions, and then be able to come back as a unified voice to come back and ask more and figure out more together. It is okay to ask for more time. Okay.
Mhm.
But also know from us that we know that everybody who comes in to see us, you want to be pregnant yesterday. So
Yes.
we're trying to get you to your destination as quickly as possible. So if you need more time to talk, process, and have those private conversations, truly private, without us being there, it is okay. You just have to let us know.
Yeah, and let us know on the front ends, because Susan's right. There's so much information that we have to cover in that visit for us to really feel like we've given you appropriate information. We have to talk about your history. Then we have to talk about, what kind of tests have you had done? What kind of tests do you need to have done? Kind of like Susan was saying. And then we talk about treatment. And for some people, they want to devour that and they want to get started like 2 days later, if that's when their period's starting. For
Mhm.
other people, they look at you like, wow, that is more information than I had any clue you're going to talk about. And they're just overwhelmed. And so, we try and read that, but, obviously we're meeting you for the first time and it's hard to really read every person clearly. So I just think any information that you can give your doctor on the front end to kind of give really at the beginning to kind of go, we're just here to learn about what kind of tests we want to do. We don't really want to do treatment right now. Or if you can give us some sense for kind of where you're at in the process, that's really helpful and be really helpful for the doctor that you see, to help you start on your journey.
I would definitely agree with all of that. And know for everybody that there's a huge range of what is normal here. And so we have a lot of people come in who feel embarrassed or ashamed that
Mm-hmm.
number one, that they're in our office to begin with, but also that they don't have a clear plan, or that when we're talking to them over the phone to say, oh, hey, we saw that you have all of this done, but you still need to do X, or your partner still needs to do X. There's a lot of times that we can hear the shame and the embarrassment in their voice because their partner's not doing what the doctor is asking them to do. And we know and we get it. And a lot of times, for thoroughness, we're not necessarily going to proceed with treatment without all the information, because it's our job to know what's best for you. And frankly, to not do something that will potentially be useless or expose you to risks that are never going to result in the goal that you want. For example, less likely to give somebody medication or do XYZ treatment if you don't know that their tubes are open, if you don't know that they're sperm. And so a lot of times we will wait, but it's very normal for all these things to happen. Sometimes you just need the time, and that's okay. And one of the techniques that I think is particularly helpful when you're talking to your partner about XYZ thing that is uncomfortable, hold hands while you're doing it, because it means it's a lot harder to cross your arms and physically make yourself standoffish. And so you don't have to, you're not obligated to enjoy it, but hold hands, because it makes it a lot easier to not close yourself off. The other thing is try different forms of eye contact. So sometimes being directly across from each other, where you are looking straight in the other one's eyes. For some couples, that's really helpful. For other couples, that is too much. They can't think while they're doing that. And so it's better for them to be side by side. And so they're both looking in the same direction rather than each other. And then the last thing that can be really helpful is to have the conversations while you're doing something else. While you are driving somewhere, go take a walk in your neighborhood or in a nice park. Go take a hike. And I mean, go take a hike in the nicest possible way.
Don't tell your partner to take a hike. If you're going to do it, take it with them.
The idea is you take the hike together.
With them.
Yes.
Yeah.
Yes. Do not tell
in separate directions.
Yeah. Like try some of those other things, because a lot of us fall into the pattern of we're really busy. And so it comes down to, okay, we have 15 minutes between finishing dinner, cleaning the dishes, and when we need to go to the grocery store for the night or go to bed or whatever. And taking time for this is helpful. And some people need the big chunk of time where they set aside an hour where we're going to go do whatever or sit here without distraction and talk about it. Other people do better in small chunks, because they need to take the information process and come back to it without feeling like their partner is feeling abandoned.
So that brings up a very good thing, because I know Dave Ramsey, the financial advisor guru,
Nashville guy.
Yes, and he often talks about that, like, one person can sit there and talk about finances forever, and the other person literally can't do it for more than 15 minutes. That's is exactly the way that my husband and I are. Like, he could sit there and he'd love to have an hour and a half conversation with me. And once in a while I can go beyond that 15 minutes, but generally he has to understand that is for something that's stressful to me, that's as much as I can give. I can give lots of 15 minutes. I just can't do them necessarily back to back.
So now, wait a minute, Susan, are you getting an MBA? Aren't you Masters of Business Administration? And you can't take it more than 15 minutes? Okay.
No, it has to do with like stress level and how personally engaging it is.
Yeah.
Okay. Yeah. And because like, it's just, I can take it for about 15 minutes and then we can come back in another 15 minutes and we might be able to talk again.
That's me.
Like my bandwidth for that type of discussion, which a discussion about your fertility, I think, is a very similar discussion, is you're going to have different bandwidths.
Yeah, okay? That's true.
And so it's okay if y'all need to break it up, but if you're the longer bandwidth person, like, just be understanding of your shorter bandwidth person.
Well, one other thing we discussed too, we sort of alluded to it, but sometimes there's certain people that are, like we said, more involved and know more things. And, maybe your partner doesn't know as much about just the female anatomy and how egg and sperm get together. And maybe they're embarrassed by that too. I think it wouldn't be bad to have a discussion starting out with, now that you've listened to us, kind of, here's what they're probably going to talk about at the visit, just to sort of get their mind thinking about it. And so that they can have a chance to sort of maybe do a little research on their own or think about it or check things out before they ever walk through the door.
And also understand that when we're talking about male-female relationships, and just because I was talking about finances earlier, what I often see is for my guys who are very stressed out about what's going on, they seem to be the most obsessive about the financial aspect of it.
Yes.
Because it's the one thing they feel like they can control, because they can't control how you're feeling. They can't control what we're telling you. They can't control what the test results are, but they're very in control of the finances of the medical treatments and those types of things. So if you're seeing that your partner is maybe a little overboard compared to where they usually are on that, you may read into, hey, this is they're kind of stressed out about this.
Their
and
version
maybe
of stress.
it's their version of how they're instead of crying like you might or bottling it up and kind of that type of thing, they may be kind of engaging their efforts in that direction. So that might be a sign to you, hey, maybe let's have some conversations. Let me be a little bit more involved in that part. Okay. And open the door for him to be a little bit more involved in the part that I'm dealing with too.
It's interesting. I see that reasonably often in even same-sex couples. The same-sex
Yeah.
partner who wants to get pregnant tends to be a lot more engaged and, talking about all these different things. And the partner who's, maybe going to be supportive in other ways, but not going to carry the pregnancy tends to be, not always, but sometimes less engaged and sort of the one you have to sort of pull in as well. And so I think it's not unique to heterosexual couples. Same-sex couples are the same way, I think, too.
On the flip side of what Susan was saying, where sometimes you need to do sometimes you need to set a big chunk of time apart. Sometimes you need to do multiple small sections of time. Sometimes you need to set aside time that says, okay, we are not going to talk about this.
Yeah.
It's very all consuming and it just can occupy every corner of your existence. And sometimes you and your partner approach that differently. Like I perseverate about things. I mean, and my husband is very good about reading me and saying, okay, we're going to go through da 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 da, and we'll do whatever long sit down about the topic. And then when I come back to it, because we communicate by text a ton. And so he'll like screenshot or refer to above saying, okay, do you need to see it again? And it's not in a mean way. It's like he can literally snapshot the conversation and say, okay, this is, here's the reminder. And it works really well. And granted, we've been together the better part of 20 years now. I am not that old. But
none of us are.
That's right. None of us are. Yeah.
Like we know each other and we know how to communicate things. And when you're in the middle of a hot topic, you sometimes forget just how much you know about your partner and think about it like, okay, if I was telling them how to deal with their other friend or their work colleague or whatever in this situation, what would I tell them? And how would I want to approach it if I was the other person? And actually distance yourself a little bit from it. So, okay, how can I say this so that the other person can hear me? Because it's not about what you understand. It's about what they understand and communicating in their language, not your language.
Exactly. Well, I think that's great.
Yeah, that's great advice. And one other quick thing too, it makes me think that a lot of times when the one partner is really emotionally wrapped up in it, it's hard for that person to talk about it without getting really upset and crying. And a lot of times for the other partner, that's the reason why they don't want to talk about it. That's the reason why they kind of put up a wall and want to walk away, because every time you talk about it, if you start to cry, it makes them feel bad, makes them feel uncomfortable. So kind of like what Carrie's saying, if you can kind of distance yourself a little bit emotionally, think as if it's somebody else talking about this and not you, and try and take the emotion out of it. And that way you can have just more of a really heart-to-heart talk about really the details and taking the emotion out of it. I think it would make it easier for both of you, if you can do that.
Cool. Any other thoughts, concerns, things that have flitted across your brain about little tidbits that you think might be helpful for couples, or just things that you've picked up on?
Use this to make yourself stronger.
That's right.
It's the two of you against this, not each of you against it and each other.
Absolutely.
Yeah. All right. Cool beans. Well, this was a lovely episode to talk about. It was fun to talk about some of the less technical stuff.
Yeah.
All right. Well, to our audience, thank you so much for listening. Be sure to tune in next week for more. Friendly reminder, we have a conference coming up October 28th, 2023 in New Braunfels, Texas, between Austin and San Antonio. And so registration is open. Go to our website. Let us know if you're having any issues. Shoot us a note on social media or through our website. And we want to make sure that this works for you. So if something's not working, please tell us, because we want to make it Like the goal is to make this helpful.
That's right.
We'd love to hear from you as always on social media, Instagram, Facebook. So send us a message about the conference or not and say hello.
You can also visit us on fertility.suncensored to submit specific questions. All questions will be answered on our Ask the Doc segment. And like Carrie was saying, we love to hear episode ideas and also subscribe to us so we can keep going and understand what you want from us.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right. We'll talk to you soon. Bye.
Bye.
Bye.